Okay, so I hereby would like to formally welcome everybody to the 79 AIOC 2021, the virtual conference. I am your MC Himay, and I would like to welcome Dr. Manish Shantilal Shah. Welcome, Doctor, and I hand over the podium to you so you can invite the speakers. Thank you.
Thank you very much. Thank you. And I think we are in time to start. And this is a instruction course, which is now a practice course. And we are going to discuss about initiating a patient on glaucoma therapy, especially an open angle patient. And before we do that, it is very important that we carefully evaluate the patient and then only decide on what strategy we can to manage the patient. So first, I would like to invite Dr. Sunil Jain, who is going to give us his talk on the basic evaluation of the glaucoma patient or a suspected glaucoma patient. Dr. Sunil, please.
Yeah, thank you, Manish. Can you hear me?
Yes, very well.
I'll just share my screen now. Can you see my slides?
Yes.
Okay. So good afternoon, everybody. And I'll be talking about a basic evaluation of a patient who presents to you in the OPD and suspected to have glaucoma or having early glaucoma. And as we all know that it's either a rise in intraocular pressure or the disc appearance and not the visual symptoms, which first identifies most of our patients who present to us in the OPD. And you could have a situation where the patient has a raised intraocular pressure, but a normal disc, or you could have a situation where the pressure is normal, but there is disc damage. That's where the confusion arises. Hence, we need to go back to our basics, and that is reevaluation. For that, you would have to elicit additional history and re-examine the eye. So from the history point of view, always ask for the history of any corticosteroid therapy of a recent onset, because over-the-counter prescription can cause intermittent rise in intraocular pressure. Other history could be a history of topiramate use, especially for epilepsy or migraine, and that the patient could present with a bilateral shallow chamber. Also, past history of any ocular trauma in the form of a contusion or a surgery might present as a secondary glaucoma. From the management point of view, always ask the family history, because if there's a strong family history of severe glaucoma, the patient might have a similar course. From the medical history, always ask for history of any allergy to all these drugs, because if you're planning to start carbonic anhydrase inhibitors, you should be aware of it. If the patient is a cardiac history or a lungs history, pulmonary history, beta blockers are to be avoided. History of vasospastic disease or very low blood pressures or past hemodynamic crisis might indicate non-intraocular pressure factors, which is usually seen in patients with normal tension glaucoma. Any history of past ocular surgery in the form of refractive surgery, as we know, it might affect the corneal thickness measurement and might have an under-recording of the intraocular pressure. Any history of any glaucoma surgery, which might indicate the bleb status. So if there's a failed bleb, that might be the cause of the rise in intraocular pressure. History of cataract surgery and whether it's caused any complications might result in secondary glaucoma. Retinal surgery, especially if silicone oil has been used, or excessive conjunctival manipulation has been occurred, we have to keep that in the back of our mind. History of current treatment is important because it might help you to rule out whether there's an over-treatment going on or an under-treatment going on. Past history of any allergy to the topical medications so that you don't repeat the same medication. Past intraocular pressure records is very important because that will give you the damage at which the highest pressure at which the damage occurred, and hence you can calculate your target intraocular pressure. Looking at the past perimetry, you will that will help us in knowing what is the rate of progression. So is he rapidly progressing or is the perimetry stable? And hence you can titrate your intraocular pressures. And there are certain syndromes which help basically clinch a diagnosis, especially on general examination. So if you have a patient with Well-Marchesani syndrome, you could have a patient who has short stature with stiff joints presenting with microspherophakia, which causes lenticular myopia. And these patients have intermittent angle closure. Also, Marfan syndrome, because of the laxity of the zonules and the lens tends to move back and forth, can result in angle closure glaucomas. So once you've done the refraction, that will help you to estimate the visual potential, and that will also help you in the perimetry. Most of the myopics, as we know, present as primary open angle glaucoma, and primary angle closure glaucoma is associated with hyperopia. External ocular examination also is important. This is a patient of non-ophthalmos, and as you can see, this is a small eye in a normal orbit. Because the eye is small, obviously the axial length is small, and these patients are hyperopic. But these patients have a normal lens. So the lens is the main thing which is occupying the volume in the eye, and that's how the patient presents with angle closure glaucoma. When you look at the lid, you could have these hemangiomas, and when you look at the sclera and episclera, you could have a prominent ropey vessels, which indicate Sturge-Weber syndrome. One has to be aware because these patients are prone to intraoperative bleedings and suprachoroidal effusions. To your left, basically, is the normal healthy virgin conjunctiva. Patient might not remember some surgery done in the past. This patient had undergone a surgical iridectomy, and the pressures were normal, but the disc was damaged. So basically, this indicates probably an acute attack, and the patient was treated surgically, and that might indicate the cause of glaucoma damage. Deposteroids are commonly used in uveitis and by the retina specialist, and the patient might not be aware of it, but as soon as you lift the lid, you might see this depot preparation, which could be the cause of the secondary glaucoma. Patient can present with diffuse epithelial edema, where it is commonly seen with a raise in intraocular pressure, but at times with a normal intraocular pressure, if the endothelium is unhealthy, as in Chandler's syndrome, you could have a epithelial edema. This is KPs in the uveitic glaucoma. You could see Crookenberg spindles in pigmentary glaucoma. Pupillary rough is very important in our population. This is how a normal pupillary rough would appear. But if you see, this is basically sphincter atrophy, indicate intermittent attacks of angle closure glaucoma. A patient could have a past history of trauma causing sphincter tears, and this could have a presentation as a unilateral glaucoma, and this is usually associated with angle recession gonioscopy. This is how a pseudo exfoliation glaucoma would present. Patient might have forgotten some laser was done. It's only on endo transillumination would you see there is a patent iridotomy, and that means probably patient had attack of angle closure, and now the pressures are probably controlled. This is how an ICE syndrome would present with full thickness and melting holes, peripheral anterior synechiae. Patient might present with Pogan-Rees syndrome, where you have pedunculated nodules and no iris changes. A normal blood vessels is what it goes radially, and it's within the stroma, as compared to rubeosis, where you can see multi-branching blood vessels, erratic and on the surface of the stroma. This is how a neovascular glaucoma presents. Normal anterior chamber depth, the center is somewhat this much. As soon as you see there's a shallowing, so probably an early onset of angle closure. As you can see, there's a glaucoma flecken also behind, and an intumescent lens causing a secondary angle closure glaucoma. Well, the anterior chamber will be much shallower. Always by vena rectus determine your peripheral anterior chamber depth. If the peripheral anterior chamber depth is less than the 1/4 of the thickness of the cornea, it indicates gonioscopy, which is mandatory. Anterior chamber lenses basically can cause secondary glaucomas. You could have vitreous in the anterior chamber, causing again a secondary glaucoma. Pressure has to be determined by an applanation tonometry. Gonioscopy is the most important thing because it helps you diagnose secondary forms of glaucomas. As you can see, you could have pseudo exfoliation, you could have neovascularization, a peripheral anterior synechiae, you could have pigmentation, you could have angle recession or inflammatory goniosynechiae. And in our country, because angle closure is almost 50% of these patients, so you have to do an indentation gonioscopy, and this will basically help you determine an angle closure component and a plateau iris syndrome. Once you dilate the patients, you will see pigment on the lens surface, which indicates a tight lens iris diaphragm, basically. And hence, angle closure glaucoma is present with pigmentation. You could have a glaucoma flecken out here. You could have pseudo exfoliation, and you could have a posterior subcapsular cataract in a corticosteroid-induced glaucoma. You could have a microspherophakic lens appearing then. You could have a subluxated lens, which could cause glaucoma. After that, you have to look at the optic nerve through basically a 90D or a 78D. And these are the features. This is how a normal nerve with normal retinal fiber layer appears. You could have a patient with early damage, early notch with a early nerve fiber layer damage. This is diffuse loss of basically nerve fiber layer. You could have a violation of the Ising rule. You could have a disc hemorrhage. These are all glaucomatous signs, basically. You could have a patient which has pallor, but the optic disc or optic cup is normal. This usually indicates a non-glaucomatous disc damage. Retina examination is the thing, and many times we miss out. And dilated examination, if you see a superior branch retinal vein occlusion, patient comes to you with a perimetry, you might feel it's an inferior arcuate scotoma, but please correlate it with the retinal examination, and it could be non-glaucomatous. Same way, a patient with a optic pit, okay, presents to you with a persistent biarcuate scotoma, and basically again it's a non-glaucomatous arcuate effect. So visual perimetry is essential, and this helps in clinical correlation, as you can see an inferior notch with a superior arcuate scotoma. Ultimately, pachymetry has to be done, which measures the thickness of the cornea and which might prevent an overdiagnosis or underdiagnosis. And after you have done the examination, you put the patient into this continuum. Depending on the damage, you can decide which stage of glaucoma he is in. So ultimately, it helps you to rule out glaucoma suspect. And if you have a patient of a glaucoma suspect, you might classify it as just an elevated pressure, that is ocular hypertension. If there's a angle suspect, then basically depending on the history, you might decide whether YAG PI is needed or not. It could be a disc suspect, so you have to do the perimetry and observe the patient. And if you have a visual field suspect, then it could be non-glaucomatous. You might do an MRI. So initial evaluation is very important, not only for early diagnosis, but diagnosing the type of glaucoma, whether it's open or closed, the etiology, the risk factors, determining the different causes of decreased visual acuity. And all this ultimately helps in giving a prognosis to the patient and predicting the results of a treatment. Thank you.
Thank you, Dr. Sunil. That was covered very well. And once we have seen the patient in detail, then we are in a position to start investigating with specific of glaucoma. And to evaluate visual fields, we have Dr. Subrata, who is going to give her presentation in place of Dr. George. She is from the Arvind Eye Hospital. Dr. Subrata, please.
Thank you, sir, for the introduction. Good afternoon to all. Am I audible and the
Yes, you
slides
are
are
audible.
visible?
No, but slides are not.
Your screen, ma'am.
You have to do the screen share, please.
Is it visible now?
Yes, now it is coming on. Yes, it is on.
Yes, ma'am, you can go for full screen and you can start the slideshow. Yeah.
Good afternoon to all. I will be reading about the evaluation of the visual fields. So assessing the visual field is much essential in glaucoma because the damage to the retinal nerve fibers initially affects the visual fields rather than the visual acuity. So the role of the perimetry is to identify the field defect. Is a field defect due to glaucoma, and is a field defect progressing or not? The most commonly used is Humphrey automated perimetry, and the results needs a systematic analysis. Usually it is divided into multiple zones for better interpretation. Just as salient features of each zone, I will be elaborating. The first zone is the patient's data and the test parameter. The most important is the age of the patient should be correctly entered because the machine compares it with the age match controls. And the refraction should be done appropriately before doing the visual fields. The pupil size ideal is 2.5 to 4 millimeter. A small pupil may give a false scotomas. As you see in this patients, the numerous edge scotoma occurs when the pupil diameter is around 1 millimeter. When the same patient undergoes the fields again with a pupil diameter of 3 millimeter, the edge scotomas has vanished. The main indices to check the reliability of the visual field is fixation loss, false positive error, and false negative error. Initially, the fixation loss was judged with the patient's response on the target projected at the blind spot, but nowadays with the gaze tracking technique, the visual fixation loss is better assessed. A loss of more than 33% is very poor reliability. False positive errors occurs mainly in the happy trigger patient when the patient responds even without the presentation of a target. This appears as a white scotoma. Here you can see the white scotoma because of the high retinal peripheral sensitivity, which is equal to the foveal sensitivity. That is very unusual. So false positive of even more than 15% gives poor reliability because it hides the scotomas. False negative error mainly occurs because of the patient's fatigability, where the patient fails to respond to suprathreshold stimulus, which he has responded earlier to his lower stimulus. So it typically occurs like a clover leaf pattern with the edge scotomas. A false negative of more than 33% gives a poor reliability of the fields. So with these reliability indices, we can assess further the field defects. The raw data gives the actual threshold score for each point. The numerical represents the decibels. So higher the number, higher is the retinal sensitivity. Lower is the number, lower is the retinal sensitivity. So usually the fovea has the highest retinal sensitivity. The maximum record in young patients is around 40 decibels. The grayscales give just a graphical representation of the threshold. One should not judge the extent of the field damage with the grayscale. The deviation plots are much important to analyze. Here, each retinal sensitivity point is compared to the age match control. So it is given as a numerical plot as well as a deviation probability plot. A probability of less than 0.5% in a normal patient has been represented as a black square. The pattern deviation plot mainly focuses on the localized deviation. This is done by correcting the deviation of the 7th highest threshold and adjusting the entire field by that value. So why is it important to have a pattern deviation plot? The total deviation plot have the depression due to both generalized depression and localized scotomas. So hence the patient with the cataract and the glaucoma, the depression due to glaucoma is hard to assess. So in the pattern deviation, by negating the generalized depression, the localized field effect due to glaucoma can be easily assessed. The global indices are single numbers, which helps us give a better clue about the visual fields. The mean deviation is an average of all the numbers shown in the total deviation, and it indicates the overall deviation. So it is the high normal range of around 0 to -2 decibel, and the high negativity is seen both in the generalized depression as well as in the localized depression. Whereas in the pattern standard deviation, the degree of difference between individual point within the field is analyzed. So it indicates more of the localized field effect. But this is not of a much help in advanced glaucoma, where there is a generalized retinal sensitivity decrease. The short-term fluctuation is usually assessed as the intra-test variation in full threshold strategy, but it is not of much value and not recorded in CITA strategies. So the visual field index is a global parameter. It is adjusted for age and it is represented in percentage. This gives us a better clue of the visual field available in the patient. So it is calculated from the pattern deviation map, with more important to the central point. The normal field is around 100% and perimetrically blind gives us a 0% visual field index. The glaucoma hemifield test assesses the zones in the superior and the inferior hemisphere. Since the glaucoma affects the horizontal nerve fibers in an asymmetrical way, this gives us a better knowledge about the glaucoma field effect. So the outcomes may be within normal or borderline or outside normal limits or general reduction of sensitivity. So with these basic ideas, how to detect a field effect, whether it is due to glaucoma. Usually glaucoma affects the superior and the inferior arcuate fibers, giving us some typical field effects. Example, central paracentral scotomas, sedal scotoma, where the scotoma arises from the blind spot into the germs area, which is 10 to 25 degree, and which may progress into the superior arcuate scotoma up to the horizontal raphe. It can lead into a biarcuate scotoma, and finally only temporal field of vision is left behind. In initial early glaucoma, some patients will have scotomas in the nasal field, which is commonly called as a nasal step. This occurs mainly because of the horizontal asymmetrical involvement of the glaucomatous nerve fibers. And the Anderson criteria helps us to judge the glaucomatous field defect better. So according to the criteria, the 3 non-edge points with at least 2 points with the probability less than 5% and 1 point with the probability less than 1%. This applies mainly for the 30-2, but in 24-2, even the edge point should be considered. And the glaucoma hemifield test should be outside normal limits, and the abnormal PSD of around P less than 5%. But in a highly suspicious case, even one criteria, if it is present, it leads to the glaucoma diagnosis. So before testing, we should choose appropriate testing pattern. So commonly used patterns are in glaucoma central 24-2, 10-2, and the macular program. So here is a patient with an advanced glaucoma where the visual field could not predict the pattern deviation in a 24-2 because of the generalized retinal sensitivity decrease. When the same patient underwent the 10-2, the better retinal sensitivity was detected in the macular area. This helps us to judge for the treatment. When the patient with the maximum medication who cannot get the target IOP, whether the surgical intervention helpful depends mainly on the macular sensitivity. So does that mean all the advanced glaucoma only needs 10-2 and the early glaucoma should be ordered for 24-2? So here is a patient with the early glaucoma with the inferior rim thinning and the inferior RNFL defect who had few central scotomas. The mean deviation in the 24-2 is -4, which points towards the early glaucomatous. So when the same patient underwent a 10-2, more scotomas, that too absolute scotoma, were picked within the 5-degree field. This implies that whenever there is a central scotoma in the 24-2 or clinical suspect of RNFL defect close to the macular area, a 10-2 and a macular program gives us a better idea about the retinal sensitivity near the macula. So always correlate with the clinical findings. So this is a patient referred to us for a glaucoma suspect with a large disc and a large cup with a mild temporal cleda. And the visual field then gives left us with a left hemifield field defect, that is left homonymous hemianopia. And the patient, when underwent MRI, was diagnosed with acute infarct in the occipital region. So thus implies the rule that always neurological defect follows the vertical meridian and the horizontal, and the glaucoma follows the horizontal meridian. So is this a field defect, superior arcuate defect due to glaucoma? When we examined the nerve, it was the anterior ischemic optic neuropathy. The field defect is the altitudinal field defect due to the optic neuropathy. So here is similar patient with the inferior vein occlusion causing the superior scotomas. Here is a patient, young patient, glaucoma suspect whose previous fields were normal, suddenly came with a field defect inferiorly. When we investigated the patient, it is because of the mask the patient was wearing, leading to this inferior arcuate scotoma. So always make the patient comfortable during the testing. It is as important as analyzing the result. Visual fields also helps us to analyze the progression. With the newest software, there are two analyses, mainly event-based and trend-based analysis. The overview pattern, which was used earlier, doesn't give us much clue on the progression of the analysis of the glaucoma. So in GP38 glaucoma progression analysis event-based, the current visual field is analyzed with the baseline visual field and with a set of stable glaucoma patients. And it is given as a possible progression or likely progression. So with this, the main, since the time is up, so always correlate the visual fields with the clinical finding, and reliability should be assessed, and don't judge the depth with the grayscale, and test with appropriate strategy and point pattern. And the follow-up is regularly is needed to assess the progression. Thank you.
Thank you, Dr. Subhadra, for your lucid presentation. And next, I would like to invite Dr. Preeti Kamdar, who is going to talk to us about evaluation of the optic disc.
Hi, Manish. I'll share my screen now.
Yes, yes.
Yeah, so I thank Dr. Manish for making me a part of this wonderful IC. Glaucoma, it is defined as a optic neuropathy, and hence optic nerve evaluation is central to the diagnosis of glaucoma. Binocular examination is the way to go, and it's best done with a slit lamp and a lens, and most of us have adapted to this method of examination. For beginners, start with a dilated pupil, coaxial eyepiece and illumination, a slit which is neither too wide nor too narrow, and while examining the right eye of the patient, ask him to look at your right ear. Basically, the eye has to look slightly nasally. Once you do that, take the slit as far as possible from the eye, hold the lens 3/4 inch away from 3/4 inch away from the eye, and now start moving the assembly towards the eye, and the optic nerve will come into view. Now, what are the features that you need to examine in a disc? So, disc size and shape, cup disc ratio, neuroretinal rim configuration, color and additional features as we will see. These are the 5 things that you need to look into. Now, first identify the disc margin. Sometimes the disc margin can be fuzzy as in this case, and you need to make a note of the same. Next, assess the disc size and shape. After that, identify the cup border. Having done this, now gauge the cup disc ratio. Remember, cup disc ratio is just one method of describing the disc and in isolation means nothing. Judge the disc size. Irrespective of the disc size, 1 million neurons will pass through the optic nerve, and hence a larger disc will have a larger cup and hence a larger cup disc ratio. If you see here, this is a large disc with CD 0.7 to 0.8, and here it is 0.2 and here it is a full disc. Physiological cupping is the epithet given to a large disc with a large cup disc ratio. Now, the visual impression of a large CD ratio makes it more susceptible to be labeled as a glaucomatous disc, and similarly damage is likely to be missed in a disc like this which has no cup. Between the rim and the cup now lies the neuroretinal rim. The real substance of the disc lies here. In this disc, it is very easy to trace it 360 degrees, but in some discs it may not be possible, and that is when the deflection of the blood vessels will give you a clue as to where the cup ends and the neuroretinal rim begins. In most discs, the inferior neuroretinal rim is the thickest, followed by the superior, then the nasal and then the temporal, and this is what is the famous Isn's rule. Progressive destruction of the neuroretinal rim, particularly in the superotemporal and the in the inferotemporal regions, is pathognomonic of glaucomatous damage. When there is complete destruction of the neuroretinal rim, it is called a notch, and when there is partial destruction, it is called thinning. This asymmetric neuroretinal rim loss is called reflex in the form of violation of Isn's rule. This is one more example where the superotemporal rim is completely destroyed, and this is also reflected as violation of Isn's rule. Now, these are two discs. Even in discs which are different, Isn's rule may not be followed, but if you trace the neuroretinal rim, you will be able to recognize focal destruction. These are two tilted discs of two different people. One to the left shows a healthy disc, it is a tilted disc, but it is a healthy disc but hardly any cup. But if you see this particular disc, if you trace the neuroretinal rim, you will realize there is an inferior notch, and sure enough the fields showed a superior arcuate scotoma. In certain discs, the notches cannot be shown very well in a photograph, but they can be seen very well in the on the slit lamp. Now, this is one example where there is an inferior notch, but it is completely masked by the blood vessel. But the deflection of the blood vessel will give you a clue, but if you are not careful, even on a slit lamp, you may miss this kind of a early notch. Having identified the configuration of the neuroretinal rim, now let us go to the color. Most of the times a healthy disc has a nice reddish tinge, but the neuroretinal rim is not uniformly colored even in healthy eyes. Typically, neuroretinal rim destruction precedes pallor, and hence it is said that cupping is more than pallor in a glaucomatous disc, and the reverse is true in a non-glaucomatous disc. So, this is one disc where the patient had a sphenoidal rid meningioma which caused the optic atrophy, and this is a disc which typically shows pallor more than cupping. One exception to cupping is more than pallor in a glaucomatous disc is when there is reversal of cupping after reduction of intraocular pressure, especially after surgery, where the cup fills up. It is filled with glial tissue, but the pallor remains, and here in this case you will find that the pallor is more than cupping, but it is still a glaucomatous disc. Symmetry between the discs of the two eyes is an important part of evaluation, and sorry about that, and a difference of more than 0.2 has to be looked into more carefully. Now the other features are like disc hemorrhage, peripapillary chorioretinal atrophy, a bearing of the circumlinear vessel. These are not pathognomonic, but in case of a suspicious disc they may tilt the balance and help you diagnose better. Nerve fiber layer examination is an extension of a disc examination, and very subtle, and they are best seen on a photograph. Now here in this particular disc you have a notch in the disc and a corresponding nerve fiber layer defect, but if you do not take a disc photograph you will miss the very subtle nerve fiber layer defect which is superiorly, and hence I have been a strong advocate of a disc photograph whenever you have a suspicious disc. Now I had always believed that if there is a nerve fiber layer defect it will reflect onto the disc, but of late that belief has changed, and if you see this particular disc there is a very subtle nerve fiber layer defect which I will completely miss on a slit lamp when I am examining the disc, but is seen well here, and the disc does not show any change, and all nerve fiber layer defects are not glaucomatous, but this was in a patient whose father has lost one eye due to glaucoma, so it is more likely to be glaucomatous. Now disc coloboma, like congenital anomalies of the disc, can be confusing and can be mistaken for glaucomatous disc, like a disc coloboma, congenital pit of the optic nerve, coloboma with an optic nerve pit. Documenting and describing the disc is also a part of an examination. Every disc cannot be photographed, but every disc has to be drawn and described, and these are just different methods of how you can describe a disc even when it is a little different. Features in my experience which people confuse whether is this disc glaucomatous or no, it is a large cup disc ratio, tilted discs, sloping rim, deep punched out cups, laminal dots. People start thinking, oh, is this glaucomatous? Now a parting tip is, you mentally categorize discs into obviously normal, obviously glaucomatous, suspicious discs and different discs, and in suspicious discs fields and OCT might help you decide. So thank you all for a very patient listening, and Manish, thank you once again for including me in this IC. I'll stop sharing my screen now.
Thank you, Dr. Preeti. It is very enlightful. And now I will call upon Dr. Pradeep Vyas, who is going to throw more light on the evaluation of the disc using imaging. Dr. Pradeep.
Hello, good afternoon, Manish, and good afternoon, everyone. My pleasure to be here, the part of this course. Can you see my slides?
Not yet.
Not yet.
Sir, open your presentation, then share your screen.
Yeah.
On Zoom.
Yeah. Is it there?
Yes, it's there.
Wonderful. Okay, so good afternoon, Manish, and good afternoon, everyone. Thanks, Manish, for having me here for this course. And just my two previous speakers, Preeti and Dr. Subhadra, taught us the perimetry and how to evaluate the test and the RNFL. Yes, I do agree with Dr. Subhadra that the perimetry is the gold standard, but structural damage always precedes the functional loss. We see the perimetry changes only when 30 to 40% ganglion cells are lost. Dr. Preeti taught us beautifully that how to examine the disc and the RNFL. But remember one thing, if you are perfect, you can do a good thorough clinical examination of the RNFL and the optic nerve. But definitely you cannot quantify and you cannot monitor the progression just based on the clinical examination. So obviously you need the equipment which is objective in nature, which can quantify and monitor the structural loss, so that we can follow up this patient, because glaucoma is a chronic progressive optic neuropathy and it causes a permanent visual damage. So that's why the monitoring of this is very, very essential. And the OCT is the one imaging technology which can fulfill all these things. Interpretation of the OCT is very important. So when you are doing a glaucoma examination, what is important, for all glaucoma patients, you examine the optic disc, you examine the RNFL around the arcuate area, and nowadays the most important is the macular part. Why the macular area is most important? Because almost 40 to 50% of the ganglion cells are in the macular area. So fortunately, the imaging technology is able to assess all these three: the optic nerve, the RNFL, as well as the macular area. What the OCT does? OCT does the scan of this 6 square millimeter area around the disc. And the most important is the 3.43 millimeter diameter around the disc. So where this RNFL is studied nicely, and the disc tomography is also studied. What it does, it opens it and it spreads horizontally, and this is classically called the Disney curve: temporal, superior, inferior, nasal, and temporal. This Disney curve is very important because it gives us the information about the RNFL thickness around the optic nerve that is surrounding the 3.4 millimeter diameter from the center of disc. The OCT has a capability of registering the image through the blood vessels configuration, and the center of the disc is also raised, and there is a tracking device where it can be tracked and automatically centered. And you can see that the green area is the very normal. The yellow is the p-value is less than 5%, and the red is where the p-value is less than 1%. So it is highly significant. You can see the enhanced image of this OCT, where you can see that this is a very thick RNFL and this is a very thin RNFL, and you can see that in this area it's dipping, the RNFL thickness is dipping over here. So if you have a complete printout, then what does it say? The first is images of the RNFL thickness, and obviously there is a comparison of the right and the left eye in the same chart. And then is the deviation map. And in the center, you get the tomography, where you can get the CD ratio, neuroretinal rim area, and the neuroretinal rim volume, and where the right and the left eye is always compared, and you can see that whatsoever the difference is there, as per the normal deviation, that will be depicted on the color-coded forms. The yellow is less than P is less than 1%, and the red is less than P is less than 1%. And here in this graph, the Tisnet curve is plotted, and where the right and the left eye is compared. So you can see that how much is the symmetry is there between the right and the left eye. You can do a good progression analysis with this. The monitoring of the glaucoma is very important, and so is the progression analysis. And always, with the clinic, we have a less time, so we want a ready-made software. And now this ready-made software is very much available, and it does the progression analysis on the basis of the three things. One is the total RNFL thickness in the 6 millimeter cube area. The second is on the superior hemisphere, and another is on the inferior hemisphere. And this is compared and plotted on the linear regression fashion. And when it is compared, then again, it shows that how much deviation or asymmetry is there between the right and the left eye. So it does give a beautiful progression analysis as well, which you can compare with the GPA of the perimetry. This is the two example, you can see that there is a significant progression over a period of time, and you can see that how much is the asymmetry between the right and the left eye. Now, another important is the GCC, the ganglion cell complex. And this is taking up the momentum these days, and people are more and more concentrating on analyzing the GCC complex. Why so? Because almost 50 to 60% of the ganglion cells lies in the macular area, and the glaucoma is the disease of the ganglion cells. So the GCC is available now in most of the machines, and what you get the thickness map, and you get the significance map over here. And obviously, yes, you get the NFAS image also, where you can see what is the thickness of the RNFL in the macular area. You can see that this area is little thinner and this area is little thicker. So there is a significant loss of the RNFL, and that you can see that it shows over here in the significance map, which is up there as a red one. So this is again the printout of this, and the GCC you can get along with the RNFL thickness map. This is showing the RNFL thickness at the right eye and the left eye, and alongside you can get the GCC map as well. So both the printout can come together in most of the machines. And you can see that with the GCC also you can assess the progression, and the progression analysis gives the deviation map and significance map. Significance map is very important, and even if you have a less time, just give a brief look, and then you would come to know that the patient is showing a significant progression over a period of time. So there are various imaging machines are available, OCT. The other imaging like the GDX and the HRT, they are out, and manufacturers have stopped manufacturing them. So we have the only one machine available with us, and all the different machines, they have a complete agreement with that. Their RNFL value might be different, but yes, the ultimate outcome is the same. Like in this, you can see that the left eye is showing the significant defect and the right eye is healthy. In another machine also, you can see the same patient, the left eye is a significant defect and the right eye is healthy. In another machine, you can see that the left eye is showing the significant defect and the right eye is pretty healthy. So there is a good agreement between all, but the data is not interchangeable or not comparable. You cannot compare the RNFL thickness of the one machine with the another machine. And there are lots of pitfalls. It's not a good tomogram. You can see that in this, it's just a 0.2 CD ratio. But when you see this, there is almost a near total coupling. So remember one thing, that the OCT is not at all a good tomogram. Once there is a blink, you can see the blink effect. And once you not capture the image, then obviously the disc is totally decentered. Though you can see that it's a very good map, but still you can see that there is lots of defect in the superior nerve fiber layer because the disc is decentered. Here you can see that it's a blinking artifact, and you can see that it's a red disease over here. That is the biggest problem of the OCT. The red disease and the white disease is the green disease is pretty common. This is a blind patient, and still you can see that lots of healthy nerve fiber layer because the glial tissue does not discriminate. So it does not have a normative database in less than 18 years of age. So that's why you cannot use in the pediatric patient. So in summary, the OCT is a good objective test. It can assess the RNFL, ONH, and the GCC. OCT printout is easy to read. It is reproducible. Registration of the image helps in comparing the subsequent report. Two different equipment reports can be compared, and ONH parameter may be different than the observed. Thank you very much for your patience hearing.
Thank you very much, Dr. Pradeep Vyas, for covering up such a vast topic in such a lucid way in such a short time. And now I would like to take my talk, which is after evaluating the patient, we need to decide on the method which we are going to use for arriving at a strategy. Can you see? After listening to the previous speakers, we have
No, sir, no.
We have carefully evaluated
File नहीं दिख रहा, sir.
and now the time to arrive at the strategy. And
कुछ नहीं दिख रहा मनीष, प्लीज रीशेयर.
Dr. Manish, your screen, yes, okay.
Now can you see the slides?
Yes, sir, we can see your
Yes,
slide.
we can see.
So as the previous speakers have given the idea about how we are going to evaluate the patient, then comes the time for us to have a strategy on managing the patient. We know that the aim of management is to control the disease progression rate such that it becomes significantly less likely to cause significant vision disability in the patient's lifetime. While trying to do that, it is very important to maintain the patient's quality of life, and your approach has to be in general practical. So practical considerations are very important. What are the factors you will take into account when you are designing your strategy? Definitely the level of damage which you are going to get from the visual field and optic disc evaluation, the age and the expected life expectancy of that patient, initial IOP at which the damage occurred, factors pertaining to the eye itself, systemic factors and personal factors you have to keep in mind. The strategy you can come out with could be observation, medical treatment, laser treatment, or surgical options. So you are going to arrive at something. The key to the right strategy is customization. So first you have to customize depending on the most important features, that is the state of the disease, mild, moderate, severe damage, and perimetry is the gold standard for us, as Dr. Subhatra pointed out, to get the level of damage. Age of the patient and expectancy we have to consider, and personal factors we have to consider before we plan a strategy. So just observation is a very important part of the management. Even the patient whom we are treating with medicines or surgery or laser, we are still going to observe them because each eye responds differently. It's not that the progression rates are fixed. Some are, even two eyes of the same patient may not respond in the same manner. And if you are trying to control the progression, determining the rate of progression is the key to finally preventing vision disability. And all these newer modalities, newer visual field software make it more reliable than we had in the past. So we are depending on calculating progression rates and modifying our treatment accordingly. The concept of target pressure is extremely central to our strategy. What is target pressure? It is a range of pressure at which this progression rate of glaucoma damage is likely to be reduced to be maintain the function vision of the patient during his lifetime. And we are going to depend on data from randomized trials and large population-based studies of open angle glaucoma and arrive at an initial target IOP, which is an estimate extrapolated from all this pooled knowledge. Then we are going to continuously evaluate the visual field and optic nerve, get individual progression rate of that patient, and then modify our initial estimate. This is well known, and I am sure Dr. Rita will cover it when she talks of medical treatment, is what are the factors we are going to consider while arriving at the strategy of target pressure, the extent of glaucoma damage, the age, and the untreated pressure. And this is a famous slide from the European Glaucoma Society, which gives us an idea that patients who have more damage need lower pressures, patients who are going to live longer need lower pressures, and patients whose initial pressure is starting pressure of damage is low need lower pressures. So that will be covered. And many studies show us what is the amount of pressure reduction required to control the disease, and various studies have targeted as the OHDS, which dealt with just suspect patients of ocular hypertension, 20% reduction was effective. In the early manifest glaucoma study, our pressure reduction of 25% was good. In the CNGT, 30% reduction achieved a very robust control of the progression rates. Before we go further, there are very specific risk factors which also have been identified by multi-center trials, which include the corneal thickness, where thinner corneas are known to be a higher risk for progressing more rapidly. Patients who seem to show appearance of disc hemorrhages during their course are also more likely to progress more rapidly, and patients who have pseudo exfoliation, as you can notice, are known to progress more rapidly. Besides that, other risk factors, which also some studies have shown, is the lower systolic or perfusion pressure. So these are the risk factors which are highlighted. If they are present, you are going to give an additional weightage of 1 or 2 millimeters of mercury more. So if the cornea is thin, or there are disc hemorrhages, or patient is having low systolic blood pressure or pseudo exfoliation, you are going to aim for lower pressure. These studies which have been done on advanced glaucoma has shown that a very robust reduction in intraocular pressure achieves a very low, almost nil progression rates in these patients, as has been shown by the AGES and the CIGIT study. They both reduce the pressures very aggressively, and they were able to show in a long period of 7 years that the progression can almost be reduced to very low. So you have to keep this in mind for patients who are really running a high risk of going blind. Overall, in mild glaucomas, you're going to target a pressure less than 18 with an acceptable range of 16 to 21 with a 25% reduction from the baseline. In moderate glaucoma, you are going to go for a target pressure less than 16, ranging between 14 and 18 with a reduction of 30% from baseline. In severe glaucoma, you would definitely like lower pressure of 12 millimeters or below, range acceptable between 10 to 14 with a 35% reduction from baseline. But in suspects, anything below 22 is acceptable, even a ranging from 18 to 24 is acceptable, and just 20% reduction is good. In normal tension glaucoma, you don't have absolute figures, but from the baseline, if the glaucoma is moderate, you will reduce 30%, and in severe cases, you will go for more robust reduction. Other factors very important to consider are family history, where patients have a history of members of their family having lost vision due to glaucoma or have progressed in a very short time. You would like to keep this in mind and be more aggressive in these patients. Even the patient's outlook, we have in the clinical practice experience that patients have a variable outlook to their disease. Some are in denial, where they believe that just some drops are given and actually nothing is wrong. And you have other patients who lose their sleep over the fear of going blind. So you have to tailor your strategy on this, is very important. Otherwise, you are likely to lose the patient. Personal factors like challenges to putting drops and financial challenges also play a role in the run. And you have to keep in mind these factors. Eye factors, including existence of ocular surface disease, a patient who has got aphakia or a complicated pseudophakia, or a patient who has macular edema due to diabetes or age-related macular degeneration, you have to keep in mind when you decide on medical treatment. So then, which are the strategy which we are going to go for to achieve this target? You can go for medical management, you can go for SLT laser, or you can opt for surgical. In the most common scenario in the early stages, most doctors and patients are opting for medical management. Why is that so? Because medical management gives you an opportunity to get more information about the individual progression rates and compliance and persistent issues of that particular patient. You also understand and make the patient understand what the fluctuations in the IOP are, and patients need to understand that IOP is not a fixed thing and it fluctuates, and the fluctuations are damaging. Also, you get a chance to know which drugs are responding well and which drugs are not being tolerated well, because even if you opt for a laser or a surgery and stop all the drugs, it is a very high chance that as time goes by, you will need drugs in this patient at a future date. The drugs only work if they are put. So adherence and persistence are the biggest speed breaker in medical management. All drugs cause some degree of side effects, hence they give a negative feedback and adherence problems arise. The surface of the eye is compromised due to the drug as well as the preservative, and that works badly for the patient's vision. Also, there are many studies which show us that prolonged drug therapy produces a situation where the surgery results are compromised and recurring cost is a problem. SLT has been recommended as primary therapy and it takes care of compliance, and there are less ocular side effects, and effects are known to last for 2 years and can be repeated, but there are practical limitations because the patients do not look upon this as a curative procedure and they want that you should have a laser procedure, then it should be curative. And they are upset that the observation of IOP and disc and fields is done just as often. In real life, patients don't accept the SLT when it's offered in the early stages and like to use it surgery. Surgery is not commonly used as the first line, but it has got advantages to offer stable IOP without medications, lower fluctuations, and more stable fields, and freedom from red eye and OSD. But it is not offered commonly because of the potential sight-threatening complications and it not being reversible. And many studies have shown that outcomes in early glaucoma are similar between medical and surgical. In the conclusion, you have to see that primary surgery may be useful in economic constraints, geographic constraints, and when you have a very advanced disease, you don't have time to try the tolerance and adherence issues, you may go for early surgery. So besides that, you have to have one strategy. I will leave it to the next speaker, Dr. Harsh Kumar, to talk to us about how the observation itself is a modality of management, and also patients on treatment also need to be observed similarly. Thank you very much. So can I invite Dr. Harsh?
Thank you, Manish. Thanks for having me here. And everything.
Dr. Harsh, can you be a little louder, please, sir?
Okay. Is that better?
Yes, sir, better than before.
Okay. So I think Manish has already started the ball rolling by telling about the observation as a strategy. And I think it is a very, very important part of our treatment. Because the most important thing is when we are not sure, it is better to let the patient be comfortable and mentally at ease. What Manish was pointing out, that we may lose the patient, we actually may lose the patient because some of them go, you say, oh, you have got glaucoma, when we are even ourselves not sure. And I have seen that a number of these patients have actually committed suicide. So one has to be very, very sure because of the presence of Google, but they can simply lose the plot. So if you are just observing, mentally the patient is at peace. There are no side effects or financial loss of putting a medication. There is no time wasted on putting the medication. But observation could be a tricky part if the patient is one-eyed. If the patient wants and demands actually that he should be treated, when he is unlikely to follow up, when he has a positive family history. Again, in the family history, you have to be very careful. So many times my students, sir, family history is positive. So just show the record of the family and then you'll realize probably there is a ocular hypertension or there's nothing much. But then there's a family member which has gone blind. In that case, you have to be very, very aggressive. So observation would be a part in OAG suspect, ocular hypertension, ACG groups, the NTG group. So let's take for the OAG, yes, we have already covered pretty much everything. Because the disc may be suspicious, fields are suspicious, OCT, that I think already you people have all talked about. Always to remember that in these kind of cases, structural damage is likely to be the earliest, though this is not the rule, that sometimes it can happen the other way too. So these have already been shown very nicely that how over the years, you must take a very clear view that they may be generalized rim thinning, they may be just small things which are happening, which you may not be able to pick up very clearly. So observation, but once you have a hemorrhage, you know that things are not in the right way. But again, if you have a bad disc because let us say myopia or morning glory or something like that, you will have a bad field and you will have a bad OCT. So it may be very, very tough to observe and how to follow up. In these situations, doing repeated pressures or repeated diurnal variations may be the answer in sometimes. And now we know then some of these bad discs, OCTA is now coming up, which may be superior to the OCT per se in determining these changes. And we now know that OCTA, even in advanced glaucoma, in advanced myopia, could tell us whether glaucoma is also occurring over. So visual field, we have already talked about. You have to check for new defect, enlargement of the pre-existing defect, deepening of the defect. And however, there are so many problems with the fields. It is very easy for us to say that, okay, we'll do 6 fields in 2 years, but where is the patient? He is not going to come for that many points. Plus, there's though we have all these strategies which have already been talked about, there is a learning defect, long-term fluctuation, already bad field, other pathologies which are going to complicate the matters for us. So, and again, OCT, like Prateek has already clearly defined everything. But yes, we have to understand that OCT would be good for you in the very early stages where it is really, really useful to detect early changes, and you can change your step from observation into action. Pachymetry is important because thinner the corneas, you have to be more very suspicious and aggressive. Just to show you how observation can also lead you to problems. A patient with one-eyed patient, 620 micron thickness, diurnal variation 20 to 24 millimeters, field is normal, disc is normal, everything looks good. And so I sit on it and I say, all right, come back after 3 months. The patient walks in after 1 year. And what we realize is, oh my God, the field is still normal, but there is a early wedge defect over here. That means already OCT changes would have shown us that there are changes. And once we go back, we realize that Parks had already told us that observation could not be a good idea if you are correcting the CCT. You know, especially in models like STAR, you may be underestimating and creating trouble for yourself, like happened in this case. So in cases of ocular hypertension, yes, you can observe, but if at any point of time 28 millimeter or more of pressure is there, family history is there, CRVO, BRVO, or there is a thin corneas, other eye is affected, OCT is doubtful, field is doubtful, and one-eyed patient. So it was already written, but I messed this up. So we have to be very careful not to observe those kind of patients. Again, primary angle closure, by definition, primary angle closure suspect will be the one in which more than 270 degrees of posterior trabecular meshwork is not seen. But if it is not seen, what do? If you start doing, you can do all these tests, but most of them are unreliable. Even an anti-segment OCT will not definitively tell you whether we have to treat it. Actually, if you go on to treat all these cases, there will be thousands and millions that you have to treat by doing a peripheral iridotomy. And iridotomy has its own side effects. Even if 5% get cataracts, we'll have a huge number over there. You will end up elevating pressure in some of them, which are absolutely normal. So again, observation as a PACS is one of the best strategies, unless you find that there is a family history of angle closure. It's a one-eyed patient. Then the other eye is having a PAC, PACG, or an acute attack, will need repeated dilatations. There is a history of intraocular pressure elevation or halos around light, which is signifying, then you should go ahead and not give up the observation part in these cases. What about plateau-iris? So once you have done an iridotomy and you dilate, you find that the angle is still getting closed. But if despite the angle getting closed, PI is okay, the fields are normal, the disc is normal, the OCT is normal, we may just follow up. Though we know that the Valsalva increases synechial closure, and there is a possibility that over the period of time there may be problems. But what can we do? Giving pilocarpine can be a big headache for the patient. Doing iridoplasty could work for some time, but not for very long time. Lens extraction obviously in most of these situations out of question. So primarily you have to observe, but very carefully, and the earliest point you may have to intervene. What about NTG? Should I treat or should I observe? So we had a case, 57-year male, came for routine eye checkup, and both eyes myopia, both eyes, right eye 6/6 vision, left eye 6/18. This eye was having a amblyopia. The disc was so obvious, superior damage here, inferior one over here. So very clear things, and that it is a glaucomatous damage. All the pressure in the diurnal variation were normal. The CCT was okay. So what are we supposed to do? So we put the patient on medication and making a provisional diagnosis of NTG and called him after 3 months. And what happens after that is that the patient walks in after 2 years, he stopped the medication in 3 months, everything is stable. And we were wondering whether we were right in starting the treatment or the patient was right in just observing himself. So this is the problem with NTG, and 40% of NTG may be okay without treatment for a long, long time. You have to be sure that it is not a steroid-induced glaucoma which has died down. Bosner-Schlossman, traumatic, sudden elevation, all these cases will settle down and need not be treated. Only treat if they are threatening fixation, IOP is in the higher range, or there is a disc hemorrhage, or there is a wider diurnal variation, there is a family history, younger age, vasospasm, or myopia. So observation has to be rigorous. 2 monthly IOP must be done, 6 to 12 monthly fields or fundus photo and OCT must be done. Must have a contact number of the patient and send them an SMS so that you are legally safe, and treat at the earliest sign of progression. Thank you very much for your kind attention.
So thank you very much, Dr. Harsh, for bringing out this concept of observation as a treatment modality. And it is very, very important that we keep so many things in mind. And now I would like to invite Dr. Rita Dhamankar to share her talk on how to initiate medical management for a patient. Dr. Rita, we can't hear you.
Can you hear me now?
Yes, yes, now we can hear.
Okay. So thank you so much, Manish, for having me in your IC today. I'm going to talk on initiating glaucoma therapy, whom, when, and how. And thank you both Manish and Harsh for having almost done all of my talk. I'm just going to kind of repeat some things that both of you have said initially. So presently, what is the principle? We know that IOP reduction is the only modality. We have many randomized clinical trials to prove that. We know that this can be achieved by medication, laser, and surgery. There are no proven neuroprotectants till now. Vascular theory is proven, but there is no treatment strategy. So finally, we come down to reducing the intraocular pressure. Can one size fit all? We have so many varieties of glaucoma. And if we try and just evaluate one strategy to treat all of them, that's not going to be the right way to approach. So we have different treatment approaches. Now, for instance, we know that if there is a patient who's got a congenital glaucoma, surgery is the way to go. However, before surgery, for a short while, we might have to use medical treatment. And at that time, the best treatment to use for the child is a beta blocker, but only a 0.25% timolol is good enough, because the surface area of that child, or the weight and the area of the child, is much, much smaller for a larger dose. If you have a patient with juvenile glaucoma, you can start with medical therapy. And if that doesn't work or doesn't prove adequately to treat the patient, you can either go for a surgical procedure like goniotomy or trabeculectomy. If you have an open angle glaucoma, he may also be having pseudoexfoliation or pigment dispersion. The way to go, like it has already been described, is medical therapy. If there is a chance for selective laser trabeculoplasty, which can also come into play, especially with pseudoexfoliation and pigment dispersion. And if nothing works, of course, we have to resort to surgery. Now, if you have an ocular hypertension, I think Dr. Harsh discussed it very, very clearly, that medical therapy options are there based on the IOP value. And like he said, if you have a value of more than 28, you just have to start treating. Otherwise, you can opt not to treat. So there are some things that have not been indicated in that flow chart above. So what about primary angle closure? So primary angle closure, of course, needs a laser peripheral iridotomy first, and then it can be followed by treatment like a primary open angle glaucoma. Secondary glaucomas need treatment for the primary pathology together with a reduction in the intraocular pressure. And like I said, for all ocular hypertensives greater than 28, you will start treatment. But for the others, you can look at risk factors together with both the central corneal thickness and the personality. So what has to be our treatment strategy? That Manish has already just discussed with us. Patients who needed to be observed have also been discussed very well by Dr. Harsh Kumar. So now we have to start deciding medications. And we have also learned that we need to get to the target intraocular pressure. And Manish has very well already explained the EGS guidelines for target intraocular pressure. So he's already told us that we got to look at the glaucoma damage, life expectancy, untreated intraocular pressure, look for additional risk factors and look at the rate of progression, and then decide whether your pressure can be high or low. And he's also told us that we can look at staging of glaucoma before we start to look at the target intraocular pressure. So depending upon whether you have an early glaucoma, a moderate glaucoma, or a severe glaucoma, you can decide on how high or low your target pressure needs to be. There have to be certain thoughts on primary medical therapy. In my opinion, you have to try and achieve your target on monotherapy. The drug that you use must be known to give a high response rate. The dosing schedule that you use has to be very, very simple. This drug has to have few to no non-responders. There should be a minimal diurnal variation. There should be minimum side effects, and it should be known for good compliance. So before you start your treatment, establish a strong foundation prior to resorting to adjunctive medication. And there are plenty of things in the history that will guide you. Like people have already spoken before, you can get a family history, because if you know that there is a very strong family history of parents or siblings going blind, then you know that you have to look at this patient more seriously. You have to look at the medical history. What if this patient has some other comorbidity, maybe a systemic comorbidity where he needs to use steroids all his life? Maybe this patient has other comorbidities like diabetes, where you know that his ocular perfusion might be at stake, or he might be more prone to a vascular occlusion. You have to look at other risk factors like his CCT, because you know thin corneas might progress much faster. By talking to the patient, you kind of get to understand the patient's personality, and you can find out what is the likelihood to compliance. You might also know whether this patient has other known allergies that can interfere with topical therapy. Also, you have to look at the presence of other present ocular surface disease, because if the patient already has an ocular surface disease and you load him with drugs which have got benzalkonium as their preservative, you know that you're going to only worsen that disease and going to cause poor compliance. And at the same time, you also have to look for a presence of concomitant eye disease. What if the patient has uveitis? What if the patient has a latent or a died down herpetic keratitis? What if the patient has a diabetic retinopathy? What if the patient has a CME? So all of these things will help you to guide what is the medication that you will actually work out very well for this patient. Now, before you start any medication, these are the 6 things I would like all of you to remember. You have to question yourself as what is the goal of treatment? What are my treatment options? What are the side effects of the treatment? What are the success rates of this treatment? Are there any new treatments coming down in the pipeline which might help my patient? And which treatment will I choose for my own eyes? If you answer all these questions correctly, you are sure to be on the right path. So what are my options? I know the target IOP. I know how aggressively to treat my patient. Which drug should I use? Should it be 1 bottle? Should it be 2 bottles? Should it be fixed drugs? Should it be unfixed combinations? I know the efficacy, the side effects, and the contraindications of the drugs that I'm using. And I also have already made up my mind on the issues with compliance. Whom to treat and how aggressively. You know that there are patients who progress at different rates, which has already been mentioned in the past. So if you look at this patient A, he's progressing very, very slowly. So you don't have to really worry about this patient. It is this patient E about whom you have to be really worried, because if you intervene him at whatever stage, you are definitely going to prevent functional loss for this patient, and you will have to treat him more aggressively. All treatment decisions involve a risk-benefit analysis, putting the natural history of the disease against the likely outcome with a given therapy. A decision to treat may arise when testing confirms progression, when eye pressure is at a level where damage is very likely to occur, or when the risk factors are overwhelmingly in favor of needing therapy to preserve vision. Now, we know that we've got so many glaucoma medications right from the year 1875 when pilocarpine was noted to 2017 when the latest batch of the Rho-Pressa inhibitors got into the market. And so we therefore are now fixed we are in a situation where we have to really make up our minds. So there is this EGS guidelines which tells us that for your first choice monotherapy, you can start with either the prostaglandin analogs, the beta blockers, the alpha agonists, the calcium anhydrase inhibitors, or others. But truly, I would tell you that my preference would be prostaglandins, and I'll tell you that in a little while. Once you started your monotherapies, look at its effectivity on intraocular pressure, look whether the target is reached or not reached, and then verify your endpoints. If not, you might have to use another drug and see whether the same thing is identified. Both prostaglandins are the most efficacious, beta blockers are equally efficacious, but reduce it only by 25%, and topical CAAs and Rho-Pressa inhibitors can only be used as adjuvants. Almost all prostaglandins are the same. When starting treatment, always start with the most efficacious drug, spend adequate chair time, explain need for compliance, make sure they know what to expect so that they will continue to use your medication, and ensure that there are no contraindications. Reassure them and reassess them in 3 months. When should the treatment be aggressive is when the presenting pressure is high, when there is advanced glaucoma presentation, when there is a faster rate of progression, when the central vision is expected to be lost in the patient's lifetime, and if there are additional factors. So then you will have to use more than one medication, 2 different bottles, fixed drug combinations, or a laser or surgery. And what about generics? Generic drugs have the same quantitative and qualitative compositions in terms of the active ingredient. A difference in adjuvants can lead to the differences in drug stability, viscosity, surface tension, and pH, which could then affect the efficacy and safety. So it is all yours to decide whether you'd like to go for the generics or whether you'd still like to stick to the original molecules. Thank you very much for your time.
Thank you, Dr. Rita. And it was a vast topic and you really covered it well. Now we have a little time for panel discussion. So I would like to put a few questions to the panelists. So first and foremost, we have all concurred that the management strategy and the treatment that we are going to dish out will very heavily depend on how the patient is responding and how he is progressing. And for progression, we know very well that mainly we are going to depend on the visual fields. So what do you do? Anyone can answer this question. You have patients who are not at all good performers on the visual field test. So what is the strategy we would adopt when you have so much variation that you have once patient is coming up with a clover leaf, another time he comes up with a white scotomas field, another time he comes up with something else, and you have these 3-4 fields you have done many times and still the patient is not able to do them reliably. Who would like to answer? Dr. Subhatra, since you spoke on visual field, would you like to answer that?
Yeah. First and foremost, we should ask the patient what was the difficulty. Once we had one patient where the repeated field showed high fixation loss, also negative errors. And when we inquired that he was a leprosy patient and was handicapped, and he was not able to press the trigger with his right hand because of the deformities. So when the patient, then after talking with the patient, when we asked him to use his left hand to use the triggers, his visual field improved. The fixation losses decreased. So first and foremost, what was the difficult from the patient side? We have to talk with the patients properly. And in spite of everything, some of the patients we do get where we will not have a very good reliable visual fields. In such cases, mainly our clinical judgment and with the newer modality of OCT and early glaucoma helps us much. But in advanced glaucoma, it's mainly the clinical scenario and the IOP measurement helps. More advanced glaucoma in old age where the visual fields are more unreliable, we go with the clinical judgment. I think.
Thank you. Yeah, okay. Would anyone like to add to what Dr. Subhatra has said? Preeti would like to say something.
Just that, yes, as she said, early glaucoma, disc photographs and OCT would be a good way to judge. But in advanced glaucomas, it's clinical judgment, intraocular pressure, and that's all you can really do, if the fields are just not reliable. So, two different scenarios. Advanced glaucoma, different way, and in early glaucomas, you have a different way of managing.
Would you err towards treating these patients a little more aggressively than you would treat other patients with a similar fields or with a similar state of glaucoma?
As long as it is medical management, yes, I would try to go the whole way. But the moment it is from medical to surgical, I would stay wait, let me get more evidence and then decide. So, in medical management, I would go the whole way, yes.
Thank you, thank you. So, Dr. Pradeep, this question is directed towards you that, there are some situations where OCTs have problems, where we have OCTs which are not reliable because of patients having tilted discs or very high myopia and a large peripapillary atrophy. So, what do you think that we should not do OCTs when you see a patient with such findings?
Okay, to reply your first question, where the Preeti and Subhadra has replied, yes, if the patient is not able to perform the perimetry, definitely OCT is the answer, because the quantification and monitoring of disease is very important, and the quantification cannot be done on the serial photographs taken. So at least you have a tool, and you have a robust database now with the tool, and it has been tested for almost 20 years now. So why not? Yes. And now, as the technology is progressing, we are learning more and more how to use the OCT. So yes, it can be used even in tilted disc, even in posterior staphyloma, even if the peripapillary atrophy is there. But yes, you have to sit, you have to catch the photograph yourself. Your technician cannot do that job, and you have to interpret yourself. Then probably, yes, you can get lots of information. Yes, sometimes, yes, the OCT is not helpful when the epiretinal membrane is there, uveitic glaucoma is there. So, you get all green disease. So it is misleading. The significant dry eye is there, media opacities are there, large vitreous floaters are there. So in these situations, the OCT is misleading and you can't help it out. But yes, if there is a difficult situation, you have the answer. We can take a good photograph of the posterior staphyloma, tilted disc, but you have to sit, you have to spend time, then you can do that.
Manish, like I was saying in my this thing also, actually I attended this thing also about OCTA. So many a time, especially in this tilted disc, etc. And if you leave the peripapillary area and macular area is okay as far as no frank CNVM or something like that, then the 3 to 6 millimeter area of the macula, the area away from the center, can sometimes really give you a very good marking as far as the where OCT per se may not be that helpful. So I think OCTA is a coming up, angiography is a coming up thing. We still don't have too much data about it, but yes, there are a number of papers which do say that in cases of high myopia and things like that, it could be very useful.
So Manish, now there is a more and more emphasis on the macular area. So even in the tilted disc and the posterior staphyloma around the disc, you can assess the macular area, you can assess the thickness over the macular area, and you can get a good clue that what is happening to that patient.
So thank you. So that is a very good, insightful discussion we had. So my next question is to Dr. Rita. The SLT, as I mentioned in my talk, it is something which is there, and it is not, we are not able to use it in the way it is described. So you have a lot of experience of SLT. So do you have patients who are on SLT for a long time? And if so, then how long?
May I request our doctors to sum it up in next 1.5 minutes, please?
Yes, so Dr. Rita can take this question. That will be the last one then.
Sure,
Thank
sir.
you, Manish, for having put this question of SLT. SLT, yes, I know, like you put it, it is only a temporary measure. So the longest that my patient has stayed on control with SLT has been a gynecologist who needed his SLT, first SLT to be repeated 3 years after the first one. And I repeated the second SLT 5 years after the first one. And only after the second SLT failed, we had to start medication. And he was extremely happy during that time. I agree that it's not the best option to offer to every patient who walks into your clinic, because they don't see it as a curative treatment and they have to spend money for the SLT, but it preserves their ocular surface, and a naive patient with no medication responds beautifully to SLT. And there's just no comparison. The patient's eyes are absolutely clean. You don't have to worry about compliance. You don't have to worry about when next will the patient come, will he not come? Because after you've done the SLT, at least for a year and a half, the patient is pretty safe. It is after that you start worrying and you call them up and say, why we need to again check you. But normally they do follow up, because you have to spend a lot of chair time with your patients anyways. Whichever ways you have to spend time with your patient. So if you make them understand that in the first instance, then I've had a very good experience with my SLT.
So I think we have reached the end of our session, bang on. And thank you, all of you, for really spending such quality time and making such fantastic presentations. So thank you very much for participation.
Thank you, Manish.
Thank you, Manish,
Thank
for
you, sir.
bearing up with us, bearing up with me with no video and whatever.
No, you are perfect. You are perfect. I didn't get to see your face. That's the only problem.
Okay. No, you've not missed anything. Bye bye.
Thank you. Bye-bye. Take care, all of you.
Thank you.
Yeah.
Bye.
So I'll take this opportunity to thank each and every speaker present out here. Thank you very much for your virtual